Hi, welcome back to educator.com. This is the lesson on the urinary system. The functions of the urinary system is not just as simple as making urine and getting rid of it. That is the primary function. It's the removal of metabolic waste. That's really what urine contains. Solid waste, of course, would be in the fecal matter, which is part of the digestive system in terms of getting rid of it. But here is all about filtering blood and getting rid of metabolic waste out of your bodily fluids. In addition to that, you have the regulation of blood volume and blood pressure. Your kidneys actually secrete hormones in response to how much blood is flowing through them, the pressure, either the lack of fluid or too much fluid, and that has an effect on your blood pressure and blood volume. It also regulates plasma concentrations of various electrolytes, various minerals like sodium, potassium, chloride, etc., because it's going to get rid of more of those or less of those through urine, depending on how much you have. And it also helps to stabilize blood pH. In addition to getting rid of stuff like sodium or hanging on to it, hanging on to H plus or getting rid of H plus, these hydrogen ions, that has an effect on pH. In addition, bicarbonate ions, which has an effect on the alkaline levels. So if you know enough about pH, hanging on to this would actually make the blood slightly more acidic. Getting rid of this would actually make the blood slightly more basic. And the normal pH for blood in the human body is 7.4 on the pH scale. That's slightly basic. It also conserves valuable nutrients. You want to hang on to certain things in your bloodstream and not get rid of them, and that comes down to kidney function. So when we look at the different organs and tissues of the urinary system, there are four main players. Here's a little drawing of it. You've got the kidneys, of course. They look like kidney beans. This is the left kidney. This is the right kidney. The left kidney is ever so slightly higher. The right kidney is a little bit lower because of the liver kind of hanging down over it. So, it's normal to be born with two kidneys. There are the ureters, which are these tubes that take recently made urine out of the kidneys to a temporary storage spot known as the urinary bladder. Just calling it the bladder is not sufficient in anatomy because there's also the gallbladder. So you want to specify that this is the urinary bladder. And then the urethra. The urethra is that tube that finally takes urine out of the body. And it is, of course, longer in males, shorter in females. I'll discuss that more later. All right, so when we look at kidneys, these amazing organs that actually make urine, you do have two kidneys on either side of the spine between the thoracic vertebrae at the bottom of the thoracic curvature, so number 12, where your last ribs are found, and down to about the third lumbar vertebra, which means that they're only partially covered by your rib cage. Just the top portion has some ribs going just posterior to it. And your kidneys actually are very much a posterior organ. There's this term kidney shot. If someone hits you right back there, right under the rib cage, and that kind of impact could definitely damage kidneys. It happens in contact sports often. But the left kidney is slightly superior, slightly higher to the right one. They are held in place by surrounding connective tissue, and that surrounding connective tissue includes the peritoneum, and it's a nice wrapping around abdominal organs that keeps them in place. And there's other neighboring organs that help keep them in place. They're reddish brown. The reddishness, of course, because of the high blood flow. There's a lot of blood going to your kidneys every second of the day. They're about 10 centimeters long, 5.5 centimeters wide, and about 3 centimeters thick, with a mass of about 150 grams each. So here are the major parts. Let's label these. So the renal cortex. Renal cortex, you see that right here. As with the adrenal glands or any other organ that has the term cortex, that means the superficial outer part of it. So the renal cortex, you're going to see a lot going on in the next few slides in terms of how the filtration process gets started. The renal medulla, or medulla, some people pronounce it that way, that's a bit deeper, just like with the adrenal medulla. So you can see that these little areas that kind of look triangular, that's really where most of the medulla is going on. And those are called renal pyramids because they do look pyramidal, triangular. So here's a renal pyramid, renal pyramid, renal pyramid. So those make up most of that medullary layer in the kidneys. And this is, of course, a cross-section, a frontal section or coronal section through a kidney. From the outside, you would not see the pyramids and, seeing that medulla. So you'd have to cut into it to see them. And then you have these two areas. They're each calyces or calyxes, major and minor. So once you have development of urine, it comes out of the medullary area into what are called minor calyxes, and all of the minor calyxes lead to major calyxes. These are the major calyxes here, and then it goes into what's called the renal pelvis. So the renal pelvis, let me use yellow for the calyxes. And here, these are the calyxes. And then the renal pelvis is this collecting area right in here. And this other term, the hilum, is kind of that exit region of the kidney through which the renal pelvis empties into the ureters. So renal pelvis is actually at the medial side of the kidneys because the kidneys kind of point towards each other, and the renal pelvises feed into the ureters, which of course then go into the bladder. So blood flow to the kidneys, amazingly, in a healthy individual, over 1 liter of blood flows through the kidneys each minute of your life. That's incredible to think about because the average person has about 5 liters of blood in their body, or 10 pints. It's amazing to think that 20% of that is constantly just there every minute going through your kidneys. So they're doing an amazing job of filtering blood. They receive blood through renal arteries. The term renal always applies to the kidneys. So here's these different parts here. The segmental arteries are right here. So the segmental arteries actually branch off of the major renal artery into the kidney. The interlobar arteries, let me show you those. They actually end up going into each little lobe. So here, 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 here. All of these are interlobar arteries, which branch off of the little segmental arteries here. The arcuate arteries finally take blood branching off of the lobar arteries all the way up to the more superficial cortex regions. So here and so on. You're going to see those arcuate arteries. And then finally, those branch off into these tiny little capillary bundles. You can call them afferent arterioles that lead to the capillary bundles. Because remember, arterioles branch off of arteries, slightly smaller, and then they lead to capillaries. So afferent arterioles, because they're going to these little filtering regions in the kidney, all these up here, these afferent arterioles, get super, super tiny to the point where they're microscopic, and they form little capillary bundles called glomeruli, and you're going to hear more about those on the next few slides. So the afferent arterioles, I'm not going to color code those. Those are all in here in the cortex of the kidney, and they branch off into millions of little bundles of capillaries. So blood leaves through the renal veins. So you have this blue little tube here. The renal veins take blood out of the kidney, the blood that hasn't been filtered out to make urine. And of course, blood flow is going to be regulated by nerves. They're called renal nerves. All right, nephrons, these are the little filtering units of the kidney. This is where all the action happens. So they are microscopic tubular structures in the cortex of the kidneys, at least that's where they begin, that do the filtering of blood and production of urine. Here's a model of what it looks like. because it's in three-dimensional space, some of the precise arrangement of where these tubes are kind of crisscrossing can vary, and you're going to see that represented in future slides in this lesson, where sometimes this little tubule is actually slightly off to the side over here, but the names are still the same based on the order in which fluid is moving through there. So 1.25 million nephrons per kidney. Wow, amazing to think about. That you're going to have 2.5 million total. Microscopic little amazing filters getting the job done. So first off, the glomerulus. Okay, the glomerulus is this little bundle here. It's a bundle of capillaries, and they go into this little capsule, and then you have certain items, water, ions, etc., moving across into the capsular space, which then leads to these little tubes, these little tubules. So the Bowman's capsule so I'm going to label actually glomerulus. I'm going to check mark there because that's in red. The Bowman's capsule, named after Dr. Bowman, I presume, is this right here. And together, you could call them, together the glomerulus and the capsule around it, a renal corpuscle. So I didn't actually write that, but this thing here, that little box that's describing the interaction between those two, renal corpuscle. So the Bowman's capsule, that leads into this here. That's known as the proximal convoluted tubule. It's twisty-turny, proximal to where this began, and then later it'll be distal, more distant. Proximal convoluted tubule, or PCT. It's this right here. Keeps going, and leads to the loop of Henle. Oh, Henle. Another scientist, I presume. That's what's going on here. So this is the loop of Henle, and there's actually two parts to it. There's the descending limb of the loop, and then there's the ascending limb going back up, and then the distal convoluted tubule. Let's use blue for that one again. So the DCT is a little bit more distant. Here it is, and then eventually we get into some other parts. This is the collecting tube, which has some ducts that lead into what's called a papillary duct, and of course that's going to lead deeper and deeper and deeper into the kidney, and by the time you get down here, it's urine, and that urine collects from all these millions of different nephrons together, going out the ureters to the bladder. So you're going to hear more about that in a few slides. So how does stuff get filtered out of a glomerulus? And plural is glomeruli. So a glomerulus is a bunch of capillaries, of course, and I didn't label this on the last slide, so I'll tell you here. This is the afferent capillary going into here, into what we call the glomerulus, and this would be the efferent one. Just like with nerves going to the brain, out of the brain, efferent neurons, it's the same idea here, afferent to efferent. They are fenestrated, and if you watched the blood vessel lessons previously, a fenestra, that means window. So instead of solute, little microscopic particles having to go through the barriers of these capillary wall cells, they don't just go through the little borders of the cells. They're actually, in each cell, are little holes, essentially, and the fenestrated capillaries make it very easy for stuff to quickly pass through that's small enough to fit through. So blood pressure forces water, because that's small enough, and small solutes across the membrane through the fenestrated capillaries and into the capsular space, the Bowman's capsule here. And some important nutrients like glucose, fatty acids, amino acids, and vitamins can also pass through. You don't want to let go of all those things because, especially if you're low on them at that moment, you need these things in your bloodstream to supply these nutrients to your cells. There is a way to get that stuff back in your bloodstream, which we're going to cover a little bit later. It has to do with them being reabsorbed into the proximal convoluted tubule. The proximal convoluted tubule. So right after we leave the glomerulus, and a mixture of water, solutes, and maybe some of those slightly larger organic compounds are coming through here, Here we're now in the proximal convoluted tubule, or PCT. It is the first segment of this renal tubular system, and it's lined with simple cuboidal epithelium. So if you remember back to the tissues lessons, we went over what simple cuboidal epithelium looks like. If you were to take a cross section of the PCT, you would see kind of cube-looking, one cell layer thick cells. And of course, they're all going to have their own little nucleus. So here's that rounded cuboidal epithelium. This would be called the lumen, the space within this tube. And reabsorption of nutrients happens here. And what's meant by that is you have water and solutes coming through here, and that's eventually going to be urine. But at this point, as you go through this tube, you can actually suck out, because of osmosis and diffusion, some of the nutrients, ions, water, and plasma proteins that happen to come in there that you want to hang on to. So as you go through the PCT, you're going to have the release of these items into the peritubular fluid that is around here. Speaking of which, if you were to look at a highly detailed version of this diagram, you would see your venous blood, or just capillaries in general that aren't part of the glomerular complex, just coming around these tubes. And so you can get that stuff back into your bloodstream once it's exited this tubule. And that's good. You don't want to let go of ions that you're low on, or plasma proteins that are important to have. Once you have some of that reabsorption occurring through this PCT, you're going to end up in the loop of Henle. And this is actually under-exaggerated. It should be much longer. Some of these loops go very deep into the medulla of the kidney. So it's found in the medulla area of the kidneys. And like I mentioned before, here is the descending limb and the ascending limb of the loop of Henle. And so what's going on here? Well, you actually have active transport occurring in this section. Earlier, I mentioned how diffusion and osmosis would drive reabsorption here. That's a passive process, but active transport actually can occur here. You're going to pump out some sodium and chloride ions, which is going to move water out of the tubule and start to make urine more concentrated. You don't want to let go of too much water in your urine. And water movement out of that loop helps concentrate the tubular fluid as the fluid moves through here. Next up, the distal convoluted tubule, the DCT, which is here and here in kind of this salmon pinkish color. It differs from the PCT that was in kind of this purplish because of a small diameter, smaller than the PCT, and lack of microvilli. You actually would find some microvilli associated with that cuboidal epithelial layer. And so what does the DCT do? It's important for three basic processes. It will actively secrete ions, acids, drugs, and toxins. So your kidneys are actually helping out with, getting rid of drugs and toxins. The liver, of course, plays a big part in that too. But your kidneys are going to help with this. That's great. Selective reabsorption of sodium and calcium ions based on your needs. Depending on your calcium, sodium levels in your blood, that's going to determine how selective that absorption is, and selectively absorbs water. So it's just finalizing what's going to become urine. How much stuff you're going to let go of, how much stuff you're going to hang on to. Finally, it's the collecting system. So we've already talked about this renal corpuscle, the glomerulus, and the Bowman's capsule. Here's that PCT, the loop of Henle, the DCT, and then you finally get to what's called the collecting system. So there is some final filtration that happens here, secretion and reabsorption. I'm going to talk more about what these terms specifically mean on the next slide. But now, concentrated urine passes through the collecting duct, this purple region, which merges into papillary ducts. So the papillary ducts get all the different collections, the urine collected from the different nephrons in this region, and finally empty into what's called the minor calyx, which I mentioned before. The minor calyxes lead to these major calyxes, these kind of hallways that lead urine into the renal pelvis, and finally out into the ureters. All right, so summary of urine formation. 3 terms that you need to keep in mind. 3 basic processes, and the first one is filtration. Filtration. That's mainly what's going on with the glomerulus, that collection of capillaries, and the Bowman's capsule. So blood pressure forces water and some other solutes into the Bowman's capsule to start it off. So that's the initial filtration from out of your blood. Then reabsorption. Reabsorption is getting the stuff that you want to hang on to out of that tube so that it doesn't escape through your urine. So water and solute are removed from the tubule, the PCT, etc., and go into the peritubular fluid outside of those tubes. Important fluids and nutrients are reabsorbed into the blood through active transport and osmosis. So as blood leaves the kidney, that stuff is not going to escape through your urine. And secretion. Solutes are transported from the peritubular fluid back into the tubule. That's the final chance to get stuff that you do want to get rid of out of that peritubular fluid where stuff's been reabsorbed, and it can go back into that distal part of the tubule and then into the collecting system. This is necessary to do because filtration alone is not enough to get unwanted wastes out of the plasma. So if we didn't have the secretory ability, the amount of wastes we get rid of every time we urinate would not be sufficient to maintain homeostasis. Urine. It's about 95% water. Sometimes it's 93%, sometimes it's 97%. This is an average for most of the time. But hey, what's the other 5-ish percent? What else is in it? So here's some main players that are going to be found in urine. Urea. It's very abundant in terms of how concentrated it is in urine versus the other things. It comes from the breakdown of amino acids. That's happening constantly in your body. It's a way to get that waste out. And amino acids, remember, the building blocks of proteins. A lot of protein stuff going on in terms of the decomposition of proteins in your body. You need to remake proteins. They don't last forever. Creatinine comes from the breakdown of creatine phosphate, which is from the muscles. And if you watch the muscular lessons, you learn about how creatine phosphate can aid with remaking ATP quickly in muscles, which is important. Uric acid, formed from the recycling of nitrogenous bases of RNA. You're making RNA in your cells constantly throughout life. So uric acid is going to be from this RNA waste. And what makes urine yellow? Urobilin is a term. Also, some people refer to it as urochrome. Urochrome literally means color of urine. So urobilin, a byproduct of the breakdown of bilirubin. That also influences the color of fecal matter. But yeah, the reason why urine is yellow is when bilirubin is broken down, and this comes from the breakdown of red blood cells from heme groups in RBCs, that by itself is yellowish. And so it makes up enough of urine to give it that yellow color. Sometimes urine is a bit more clear, and that typically means the specific concentration of water is just much higher. So if your water is clear, that means you're super hydrated. You have so much water relative to other times that you're getting rid of that water. You've taken in so much water, you don't need that much. Or if your urine is clear, it could mean you're drunk. Because you'll learn about this in a future lesson if you look at the alcohol lesson. The ADH, antidiuretic hormone, that ability to hang on to water in the kidneys is definitely damaged by alcohol intoxication. And the amazing thing about urine is, even though some people will find it disgusting, there's nothing that's actually harmful about it in terms of bacteria. It's sterile. Unless you have a urinary tract infection. But urine itself is sterile when it comes out of the body. There's no bacteria in it. You may have seen survival shows or a list of things to do if you're stranded on a raft in the middle of the ocean or in a desert where there's no water, no moisture. If you want to prolong life, one of the things you can do is drink your urine because it's a way to get those fluids back into your body that you just let go of. And eventually, if you just keep doing that, you're going to stop making urine because you're not introducing any new water in your body. But even though that's disgusting to think about, it can keep you alive for a little longer. But if you urinate into, let's say, a bottle, and you wait a while, let's say you don't drink it right away, you just wait hours and hours and hours. In that bottle that you just urinated in, there was bacteria. And your urine is warm, has nutrients, bacteria are going to start eating stuff in there and dividing. So if you do leave the urine in the container, that could introduce a bacterial infection into your body. But urine itself, sterile. The ureters, that is what is actually taking urine down into the urinary bladder. It's a pair of muscular tubes, here in yellow, that connect the kidneys to the urinary bladder, firmly attached to the posterior wall. Remember, the kidneys are found in the back portion of your abdominal region, so the tubes that are coming out of it are going to be right there. 3 tissue layers, similar to what we saw with digestive system stuff. Inner mucosa, that's actually adjacent to the lumen, that's where urine is going to be. Muscular layer, because you do have to help move along the urine, and the outer connective tissue that's going to help keep these tubes anchored to the neighboring tissues and organs. Peristalsis, we've seen that term before, with moving your digestive stuff through, also through moving through the fallopian tube, ova, eggs waiting for sperm. Peristalsis, this wave-like muscular contraction, actually happens here. It sweeps urine down through these tubes. It's not just gravity taking them down. The sweeping muscular action of peristalsis actually gets urine constantly into the bladder. Your urinary bladder, hollow muscular organ that is a temporary reservoir for urine, of course. It can hold as much as 1 liter of urine. So think about one of those soda bottles, it's 2 liters. That's a lot of urine. That's when you're really going to have to go. Because just as much as 200 milliliters of urine, 20% of that is going to initiate some urinary reflexes that are going to start preparing your body for urinary time. The rugae, so when we look inside of the urinary bladder, you're going to see folds similar to what you see inside of a stomach. So the rugae, those little folds, as the urinary bladder expands, as it holds more urine, those rugae are less obvious because of the stretching mechanism of the bladder. The trigon is this triangular feeding area that urine is going to be collected into and then eventually emptied into the urethra. The border, though, between the trigon and the urethra is the internal urethral sphincter. Sphincter is always a muscular kind of doorway from one part of a tubular passageway to another. And in this case, this is involuntary. You do not have voluntary muscular control over this. This is going to open up as stretching happens in the inferior parts of the urinary bladder. So that need to urinate, as the internal urethral sphincter relaxes and lets more urine out, that's when you need to go. So the urethra is that final tube leading out of the urinary bladder and then out of the body. So it extends from the neck of the urinary bladder and finally exits out. Longer in males than in females. And you can see from this image here, when you take into account the external genitalia of men, the urethra can sometimes be 8 inches long because you're also including the internal part prior to it entering the penis that empties out of the bladder. So if you take into account penis length in men, the urinary tract is going to be longer. In females, it's only about that big because once you come out of the bladder, you're going to hit the external genitalia of females. And so the UTI likelihood, urinary tract infection likelihood, is actually much more common in females, which I'm going to talk more about later. The external urethral sphincter is what is the final muscular doorway that's not letting urine out. You have voluntary control over that, similar to the external anal sphincter. So voluntary control, you can hold that to a point, but once your bladder is filled up, to that 1 liter max and urine is creeping into the urethra, the need to let it go is going to happen. And micturition is the technical term for urinating, and the micturition reflex, that's going to happen as you get stretching in the bladder, as your neurons connected to the bladder get sense of that stretching. It's going to send a signal to the brain and then send a signal back down to the voluntary muscles when you actually actively urinate. But remember, there is involuntary parts too. As the involuntary muscles relax, the need to actually finally let it go is going to happen. So urinary conditions and disorders. Like I mentioned a bit ago, UTI, urinary tract infection, much more common in women because it's typically a bacterial infection. And if you think about the urinary tract of a female being just this big, the ease for bacteria or ability to take over this region happens much easier. So the dividing of the bacteria can quickly invade that tube. If the tube is this long, it's less likely that the bacteria are going to be able to conquer that tube and cause significant urinary tract infection. It does happen in men, don't get me wrong, but it's just more common in women. Kidney stones. Kidney stones happen in men and women. I've heard that they happen slightly more in men. I don't know if that's dietary differences on average, but kidney stones can happen for a variety of reasons. It's basically a collection of hard deposits in parts of the kidney over time, and they're so hard and so large relative to the sizes of the tubules in the kidney that they cannot get out completely through the urethra, and they do get backed up. You can see an image here. These are actually fragments of kidney stones, very tiny. You can see that at most they are half a millimeter in diameter, so very tiny. But if you think about how tiny the tubules are leading urine out of the body, you can see how they get stuck. And of course, you're going to get a backup. They're very painful. One amazing way that you can get rid of them that doesn't require surgery is they've learned that if you project sound waves at the kidney, you can sometimes shatter these kidney stones into tinier bits that can naturally be eliminated from the body, which is amazing to think about. So the technical term is renal calculi. Renal calculus would be one. Kidney dialysis is accompanied with renal failure. So if somebody's kidneys are just not getting the job done of filtering their blood, you will hook them up to a machine that basically filters their blood for them. And since the kidneys also have a lot to do with stimulating the making of red blood cells and other cells in the bone marrow, drugs that help make red blood cells will also be introduced into the body in addition to the filtering of their blood. And this is a temporary solution. Kidney dialysis does not cure kidney failure. It will prolong life, but the need is for a kidney transplant. You can get a transplant from a donor who is deceased, and I've heard that that's 85% effective on average. If you get a kidney from a relative who's alive, your likelihood of success and prolonging your life is more like 90-something% in terms of adding years on your life and it being a successful transplant. But people who do get kidney transplants, they need to take immune suppressing drugs, because even if it's your brother that's donated one of his kidneys or a cousin, she's donated one of her kidneys, that's not your kidney. And the precise protein makeup on those kidney cells is not close enough to fool your body into thinking, oh yeah, it's our cells. So you actually would have to take immune suppressing drugs to kind of calm down your immune system's response to that tissue introduction. And that makes a person who's received a kidney transplant slightly more susceptible to other illnesses. But hey, it's worth it in prolonging your life. Glomerulonephritis. So nephritis basically means like infection affecting the nephrons, and it has to do with the glomerulus coming into that region. So the amazing thing about this is the infection is not in the kidney itself, but some infection in the body is now affecting the kidney negatively. And the reason why that negative impact happens is with certain infections in the body, you're going to get a buildup of a lot of different antibodies in response to antigens. That's part of your lymphatic system's ability to beat the illness. But that buildup can actually, when it gets into the glomerulus, that can really affect blood flow out of the glomeruli into those corpuscles, and into the Bowman's capsule specifically. So this is an infection that has negatively impacted the filtration ability of the kidney. And then incontinence. This is the inability to fully control when you're going to urinate. And this tends to happen more in older people as they age. The muscular tone in terms of like keeping urine inside is not as good. Also, strokes and Alzheimer's can have an impact on that ability to control urination. And it also can happen in pregnant women too. The baby is going to take up a lot of space in that region of the abdomen. And it can not only press on the bladder, but also stretch out some of those urethral muscles. Makes it hard to hang on to urine during pregnancy for some women. So thank you for watching educator.com.